Hello everybody, my name is Regis Paulinelli, a breast oncoplastic surgeon from Brazil. Thanks to the International Association of Oncology for the invitation to this webinar. I will talk in the next 20 minutes about what would be the best guidelines for breast cancer awareness that we should follow. According to the World Health Organization, cancer is already the leading cause of death worldwide. We had around 10 million deaths in 2020. Both Brazil and India face a high cancer death toll, unfortunately. There were 2.26 million breast cancers in 2020, according to the World Health Organization. Breast cancer is the leading cause of death in most countries, including Brazil and India, especially among women. The incidence of breast cancer is lower in the eastern countries and higher in Western countries. But in India, 34% of women with breast cancer will die of it. In Brazil, 15% will die. In developed countries like the United States, only 12% will die. How could we reduce breast cancer incidence and mortality rates? Reducing breast cancer incidence is called primary prevention. This way we could prevent some breast cancers to occur. What are the main risk factors for breast cancer? There are many risk factors for breast cancer. I would like just to highlight some of them. Some of them we can change, like being a woman. Women have 100 times more breast cancers than men. Incidence rates increase with age. Breast cancer is 6 times more common after 50 years old than before. India and Brazil have a relatively young population, but life expectancy is getting better. So we expect that breast cancer incidence may increase when our population grows older. Family history is also important, and some cancers may be caused by pathogenic genetic mutations, like those occurring in the BRCA1 and BRCA2 genes. But every woman should be cautious about breast cancer. 70% of breast cancers occurs in women without family history. In Brazil, 1 in 10 women will get breast cancer. In India, maybe a little less. In Western industrialized countries, 1 in 8 women will have breast cancer. Hormone factors are important. More exposition to female hormones is related to more cases of breast cancer. So early menarche, late menopause, prolonged hormone therapy, for example, could increase breast cancer risk. Breast cells differentiate with pregnancy and breastfeeding. So women without children or getting pregnant after 30 years old are more susceptible to breast cancer. There are some premalignant breast lesions that work as markers for breast cancer risks, as atypical hyperplasia, for example. We still can't change our age or genetics, family history, or age at first period. Women nowadays have fewer children and delay the age at first birth. But if we change lifestyle, up to 68% of breast cancers could be prevented. Preventing obesity is mandatory. We could reduce 32% of breast cancers this way. Obese women produce more female hormone in the fat because of an enzyme called aromatase. We can stimulate physical activity in breastfeeding. Alcohol intake is also related to breast cancer. It's also well established that a healthy diet rich in vegetables and fibers can reduce breast cancer. If we were able to identify high-risk women based on family history and genetics, we could also use medicines like tamoxifen to reduce breast cancer incidence in some women. For some women with pathogenic genetic mutations, there is the possibility of risk-reducing surgeries like oophorectomy or mastectomy. But as I said, 70% of breast cancer survivors don't have any family history. a high risk genetic mutation will be found in just 10% of breast cancers. Early diagnosis or secondary prevention is very important. Here you can see the survival curves according to the stage of the disease in 10 years. If we find in situ carcinomas before they invade tissues, 98% of the women will be cured with surgery alone. And mortality rates increase with tumor size and lymph node involvement. Unfortunately, in the case of metastasis, most women will be dead in 10 years, unfortunately. So early diagnosis is important in reducing mortality and preventing more aggressive treatments. Here you can see the results of the most important screening study using mammography. In the 70s and 80s, some randomized studies were conducted. At that time, researchers randomized if a woman would get a mammogram or not. It was ethical at that time because we still didn't know the real benefit of a breast cancer screening program. Almost all studies show the great benefit of biennial mammograms after 40 years old and especially after 50 years old. On average, there was a 25% mortality reduction in the screening group. It's important to know that ultrasound or MRI doesn't replace mammography. They can find other missing cases of breast cancer, especially in women with dense breasts or high-risk women, but they increase costs and distress because they find many suspicious benign lesions that will need a biopsy at the end. Both ultrasound and MRI have high false positive rates. I don't believe we will have new randomized studies about screening programs. It would be unethical nowadays. We already know the importance of mammographic screening programs. This recent Swedish prospective study with more than 500,000 women showed a great survival benefit in serial participants of the Swedish screening program in comparison to those less adherent that would skip the mammogram sometimes, and much better than in serial non-participants. Serial participants have 50% less risk of dying in 10 years than non-participants. Those who believe in mammographic screening are from time to time haunted by the ghosts of the Canadian study. Once in a while they release a new analysis of their study with updated follow-up. They haven't found survival benefits in annual mammography, and they stated that 22% of screen-detected breast cancers were overdiagnosed. They believe some of these tumors will never develop or lead to death. There are many criticisms of this study. It was conducted in the 80s when mammograms were getting popular because of the other studies' result. Scientists believe that some women in the control group got their mammograms done. Experts have mostly suspected issues with randomization, which they say would have skewed the findings. When interviewing 28 staff members who worked on the original study, some confirmed there were multiple instances in which women with detectable lumps who were pre-screened by a nurse were in fact purposefully placed in the mammography group. The same could have occurred for high-risk women who were willing to have a mammogram. Actually, not all cancers detected by the screening program will have benefits. There are some tumors, like tumor A in this graphic, that may be less aggressive, especially in older women. Surely some women would have died from other diseases without the diagnosis of breast cancer. On the other hand, there are some very aggressive breast cancers, like tumor D in the graphic, that would appear as metastatic disease even with annual mammograms. There are still others, like tumor C, that would progress after an early diagnosis despite the screening and treatment. Only women with tumor B diagnosed in an early stage and cured by treatment will get the benefit of the screening. For a screening program to be effective, there are some conditions. We should be able to identify the disease in apparently healthy individuals. We should recall the patients to do their exams. In the case of a suspicious finding, there should be a quick access to diagnosis and treatment. And for breast screening program to be effective, more than 70% of the target population must participate regularly. You can see here that the current recommendations for breast cancer screening are conflicting. The main world institutions don't agree on when it should begin, at 40, 45, 50, or the periodicity, annual or biennial, when or if it should end. Studies with self-examination didn't show benefit. There were more benign findings without reducing death. Clinical examination is still controversial. The Brazilian Society of Mastology still advises for self-examination and clinical examination because we don't have in Brazil, like in India, a structured screening program. It's only an opportunistic screening. Doctors just ask mammograms when women come for routine visits. Unfortunately, more than a half of breast tumors in Brazil are found by the women themselves. When they come to our office, we advise an annual mammogram after 40 years old, up to 70 years old, or more if the woman have a good life expectancy. In a 20-year study, clinical breast examination conducted by trained female health workers in Mumbai led to a downstaging of breast cancer at diagnosis and reduced mortality from the disease by nearly 30% in women aged 50 years old or older, but with no mortality reduction seen in women younger than 50 years old. Clinical breast examination should be considered for breast cancer screening in low and middle income countries like Brazil and India. I'm sure of that. Although we aren't a rich country, there is a reason why we believe our women should begin mammography screening at 40 years old instead of 50 years old. Our population in Brazil is much younger than that of the developed countries in Europe and North America. The same is true for India. Because most women are young, most cases of breast cancers occur under 50 years old, as you can see here. If we recommended beginning mammography after 50 years old, after every 2 years, ending at 70 years old, as suggested by the public health system, we would find less than a half of breast cancers. If we could perform mammography in every woman annually after 40 years old, we could detect almost 90% of breast cancers. That is more than the 70% necessary for a breast screening program to be effective. Many women in our country rely on the public health system. They face difficulty in finding a doctor or having a mammography. We are far from the ideal. Only 60% of women between 50 and 69 years old in Brazil had a mammogram in the last 2 years. Breast cancer cures depends on early diagnosis, quick access to a breast surgeon or breast oncologist, and adequate treatment. Much money is being spent on chemotherapy and new drugs. It's very important, especially for locally advanced breast cancer. But 80% of breast cancers will be cured because of surgery alone. Hormone therapy will cure 10% of the cases. Another 10% will be cured because of chemotherapy and radiotherapy. It's very important that any woman with breast cancer have a quick access to treatment. Delays in starting treatment of more than 2 months are related to increased mortality. We can see it clearly if we compare breast cancer survival rates among women treated by private practice and health insurance with those needing to rely on philanthropic institutions and the public health system in Brazil. Poor women must wait longer for screening, diagnosis, and treatment. That's why they live less. The difference is still more evident in locally advanced breast cancer, in which the quick access to treatment and access to new expensive drugs is still more important. As I said, surgery is responsible for 80% of cures. But we don't need to be too aggressive in surgery. We have enough level 1 evidence to say that a conservative treatment is equivalent to mastectomy for most cases. Here you may see 6 randomized studies. Local recurrence and survival were similar in quadrantectomy and mastectomy. Sentinel node biopsies nowadays replace many indications for axillary clearance, and it's a fantastic achievement because there is much lower morbidity, like less lymphedema and shoulder disabilities. There was an increase in bilateral mastectomy in the last decades because of fear, but for most women the risk of contralateral breast cancer is low. A bilateral mastectomy doesn't impact your cure or survival. Breast reconstruction is not the same as a natural breast. There is a much higher risk of complication and dissatisfaction. It's important that women and doctors be aware of it. I believe the only real limitation for a conservative treatment is our ability to leave behind a good cosmetic result and a good symmetry. These are some real patients that came to our service referred by other surgeons for a delayed reconstruction after a conservative treatment. Nobody wants to have such poor aesthetic results. And the 2 main tools that we have available for increasing the indications of conservative treatments are neoadjuvant chemotherapy and oncoplastic surgery. That is the association of plastic techniques with oncologic techniques. I dedicate myself to oncoplastic surgery and breast reconstruction, and I believe it's very important for the women to keep a good self-esteem. There is a law in Brazil that guarantees that all women must have access to breast reconstruction. Still, only 40% of the women in the public health system in Brazil needing a mastectomy will get a breast reconstruction. I believe the situation may be similar in other developing countries. We have a lot to improve, and our women with breast cancer deserve it. At the beginning of the pandemic, I created a website to help colleagues and alumni interested in oncoplastic surgery. It's called oncoplastic.com. Now thousands of surgeons around the world are using the website as a learning tool. I'm very happy to be able to contribute in some way, and I invite you to visit it. I will make my presentation available there soon if you want to see it again. Thank you very much for the opportunity to be here with you.